Hi, Muhammad Al-Mali here with another case of a small pupil cataract surgery. This is case 6 of our small pupil cataract surgery series, and this patient is having a toric IOL placed along with their cataract surgery. The steri-strip you see down here at the bottom right of the screen is placed because during the draping, my tech didn't get all the lashes, so rather than trying to re-drape the patient, I put a steri-strip there to cover those lashes and prevent them from getting into my field and contaminating my instruments. So this pupil is a little bit over 4 millimeters. You can see there's a lot of debris in the tear film, making the visualization more difficult with the extra steri-strip there. When we hydrate or irrigate, the fluid can get backed up, but nonetheless, we have a decent view here. We've already injected visco into the anterior chamber. We've achieved some viscomydriasis here already. The pupil looks already about 5 millimeters here, which is plenty to do a capsulorhexis. 0.12 forceps to stabilize the globe. We're trying to irrigate all that stuff off before we do the capsulorhexis. It's best to irrigate right at the limbus, temporal limbus there, and that helps to draw all that material off of the cornea rather than trying to irrigate right over the center of the cornea. And you can see my tech did that. It really pulled a lot of that material off the ocular surface. So continuous curvilinear capsulorhexis here. We've already used a cystotome. I use my capsulorhexis forceps, cross-section forceps here. We're not afraid to go right to the pupillary margin. Regrasp as needed. Every time before I regrasp, I bring that capsule back so it's easy to regrasp. So before I let go, I'll bring it back again so I can regrasp. Well, it looks like I'm not going to regrasp it. I'm just going to finish the capsulorhexis. If you go back and watch that or watch my other videos, every time I regrasp, I want to bring the capsulorhexis back and make it easy for myself to regrasp that rhexis. So we're going to try and achieve a cortical cleaving height of dissection. We're going to tent up here on the capsule. Small pupil cases, watch out for iris prolapse. As soon as you see it happening, stop irrigating and depress in the posterior lip of the wound to decompress the anterior chamber. So here it looks like I'm having a hard time getting a fluid wave, and so I may end up just not worrying about doing cortical cleaving hydrodissection, and sometimes I'll even just hydrodelineate and do our best. So once that viscoelastic is out of the anterior chamber here, you can see that pupils come down a little bit now, maybe 4.5 millimeters at this point in time. Still plenty of space to be able to do this case. We'll go in with the phaco probe. This is a case from this year, I believe. So we have the Alcon Centurion machine, and we're going to do our horizontal chop maneuver with the Nagahara chopper. I'm going to take that phaco probe, impale the center of the nucleus. We'll reach out beyond the capsular edge there, and we'll do a chop maneuver. We've got a nice crack and a decent rotation so far. Okay, we're doing two hands here to do the rotation. We've got a decent rotation. Two things you got to have in these small pupil cases. You got to have a good crack and you got to have good rotation. Otherwise, the case can be significantly more difficult. And you add that, it can make it more difficult in any case, but especially when you have a small pupil and you have a poor crack or a poor rotation, it can just really make all the strikes really pile up against you. So we've already chopped one heminucleus. We're going to chop the second heminucleus, and then we should be starting to remove these pieces here pretty soon. I use my quadrant removal mode throughout this part of the procedure. I find that helps to impale the nucleus. This is a large lens. You can see here I'm pulling out that quadrant. It's a large lens. It looks fairly dense, and so it can be a struggle to do these cases and the patient has a small pupil. But nonetheless, looks like we're making good progress. So whatever settings I'm using here, I'm not entirely certain what my settings were at this point. They seem to be working well. So I use my second instrument a lot when I'm operating. I use the second instrument to move that piece, to separate it mechanically from the other pieces so it can tumble. And we are getting good phacoemulsification here, and it's really doing a good job. This machine is really doing a good job eating up these pieces. So we've got 2 quarters remaining. We'll mechanically split them again so we can get them to tumble. And that's especially important, especially when the pupil is small. Large nucleus here, especially with that small pupil. But we are making good progress here. I already have my second instrument behind my lens material that I'm trying to chew up here. I'm using the second instrument to protect the posterior capsule, especially since I really can't see it. And I really don't have too much behind this phaco probe at this point in time other than this lens material. And then we have one more quadrant remaining. Looks like we do have some cortical material there, so we will probably be doing irrigation and aspiration here. So last quadrant, really nice, making good progress here. Second instrument protecting the posterior capsule. We will go in now with IA to remove that cortical material. While I'm waiting, I'll inject some BSS through the paracentesis, keeps the anterior chamber formed, removes any of that nuclear material that may be bunched up in that paracentesis. I hate when I'm irrigating at the end, all that stuff just comes out. I have to go back in there with the IA handpiece to remove it. So I go ahead and irrigate out while I'm waiting for the handpiece. Really, it gives me something to do while my scrub tech is getting things ready for me. So not really much of a cortical cleaving hydrodissection here. You can see that cortical material is really stuck to the capsule. We're going to have to peel it off here piecemeal all the way around, and that's okay. We didn't get that great of a fluid wave, and it shows here, but that's okay. We're going to do IA, and we're going to remove this cortex, and this patient's going to do fantastic. All right, so some cortical material still there remaining, not too much. I'll probably go in with my Terry Squeegee capsule polisher. Optional to do that, but I like to see that posterior capsule nice and clear. So I'll do it for almost all my cases. It's Terry Squeegee. It's a cannula with a silicone tip. It polishes the posterior capsule through two mechanisms. Number one, irrigating it and just using that fluid to wash off any material, and also mechanically, you can mechanically use a silicone tip to push and remove any cortical material. So ProVisc here, cohesive viscoelastic. You see what I did there? I went to the left of the wound and the right of the wound, and what I'm trying to do there is remove any pieces that may be lodged in the anterior chamber angle, so we're not left with any surprises. We are doing a toric lens, so I'm going to use the intraoperative aberrometer, and I'm going to use that to help align my toric axis. Many different ways to do this. You can mark the patient in pre-op, many different machines to be able to do this. I use the Aura machine. We've had it for over a decade, and we use the reticle on there to align the axis and measure how much residual astigmatism we have on the fly in real time. So the patient's fixated there. We took the measurement. I've already decided what IOL I want to use, and I'm just using the toric for alignment of the axis. So once I've made the capture, I'll go ahead and insert the IOL, and then I'll go in with my IA to position the IOL and rotate it into the proper axis. A little bit of a delay here. Not sure what I'm waiting for. So I may be asking my tech for something or needing something, or she may not have the IA handpiece ready. In any case, here is the IA handpiece. When we use that to push the IOL into position, the advantage of that delay is now that the haptics are unfolded, we see the toric markings there, and we see the Aura reticle is telling us where to place the toric IOL. Once I get it roughly in position, not exactly in position, maybe a little bit kind of clockwise to where my final position is, I'll go ahead and remove that viscoelastic material with IA, and remove any remaining cortical or lens material that may be in the anterior chamber also with IA. I like to go behind the lens. Don't have to do that, but I do like to do it just to make sure that there's no remaining viscoelastic trapped between the IOL and the posterior capsule. So once we are happy with that, then we'll go ahead and look at my toric markings again, look at the reticle. I have my tech turning the reticle on and off for me as I see fit, and it looks like I'm happy with that placement. And then I'm going to pressurize the anterior chamber, and I'll take a look at probably the Aura screen to make sure that things are nice and oriented with minimal astigmatism remaining, and the Aura is not telling me to rotate right or left. So once I get the eye pressurized to where I wanted it to be, then I'll look at my toric axis to see and make sure that I'm happy with how much residual still there is. So actually with the reticle there, you can see it does give you, the top number there is how much the amplitude of the still as well as the axis of the still that's remaining. So we can see we're right around 0.4, 0.3, 0.2 still in the anterior chamber in the whole eye system. So we've gotten our residual astigmatism less than half a diopter, maybe even 0.3 diopters of residual still. So I'm happy with that. I like that. I'm going to check the wounds, make sure they're watertight. Looks like I'm happy with that, and then I'm going to go ahead and remove the lid speculum, and that is the case. So, continue with our small pupil cataract surgery series. If you have any questions or comments, please leave them below. And then we'll try and put together a video just summarizing what we've learned from this series. Thank you for your attention. I hope you learned something here. Thank you.